So what I'm going to do is give you a real whistle-stop tour of this. Apologies for the disruption there. And just start with what's on the slide here, which is our trauma flower. And this is our attempt to pull together the sort of themes that should be evident for people accessing services and for those who deliver services when we achieve that trauma-informed element, with the key elements of services being offering choice, empowerment, trust, collaboration at the centre of that, but also thinking about around the rings of the circle, about the policies and the environments and the importance of that sort of structure across organisations, and the real value of having this work referenced in the last 6 consecutive programme for governments, and the subsequent incorporation in really key policy areas. We've seen it crucially threaded through the promise. It's in the National Workforce Strategy for Health and Social Care, and just the other day there's been the new publication of the Drugs Death Task Force response, and that is just a few of the key policy areas that will be relevant to your area of work. At its heart, it's the recognition that trauma is common, that people who are impacted by trauma are at higher risk of poorer outcomes, and those people are often the people that have the hardest job getting into services and experience additional barriers. And all of this contributes to the increased inequalities for our citizens, and particularly as we move through the pandemic and the additional challenges that has brought. So just to kind of get into this in a wee bit more detail, I'm going to move from flowers to trees, and this diagram is a representation of probably thousands, but certainly hundreds of research articles across the last 20 to 30 years. And they tell a story of what can happen where systems are not trauma-informed. So hopefully flipping all of this gives us a really much more hopeful message. But let me just start with the roots of this. What we're talking about here is trauma. So that's more than just stressful events. And so these are events that are considered to be life-threatening or threaten our sense of safety in the world. So we're talking about events like domestic abuse, childhood sexual abuse, life-threatening illnesses, car crashes, terrorism, war, all of these events. And some of these you'll see it's divided into single incident trauma. So that's things that happen once. And then we have complex traumas, which are things that often happen over many years. And we know the importance of traumas that are experienced over time, so it's things like domestic abuse, or traumas that happened in childhood or early adulthood are at particularly high risk of leading to poorer outcomes. And really those opportunities to get upstream and early in terms of the way we respond to those. And one of the reasons I personally moved from clinical practice delivering therapy to survivors of trauma to more sort of education and sort of the planning was a frustration at the range of lost opportunities. That something we could do something earlier at this stage. You also notice in the roots that other adversities, poverties, inequality, bereavement, racism, all of these things have a part to play, and it can exacerbate the risk of poorer outcomes. There's a complicated bi-directional relationship between all of that. So it is good to hold those broader adversities in mind as well. Why does any of this matter? Because we know that trauma is common. If we take the whole population across Scotland, we'll know that about 20% of women and somewhere between 5 and 10% of men, the latter may be an underestimate, well, both may be an underestimate, but have been exposed to childhood sexual abuse. And about 25% of women have been exposed to domestic abuse. So these are really high numbers. But if we look under the bonnet at the services that Europe provided, the data becomes even more stark. So we think about substance use services. The World Health Organization has produced figures that tells us about 75% of people who use substances have experienced trauma, and that once people are using substances, the risk of experiencing further trauma becomes almost ubiquitous. In mental health services, looking across a whole range of studies, about 50% to 75% of people across most studies who experience mental health problems have a trauma history. And if we could eliminate trauma, we could get rid of about 1/3 of all mental health difficulties. In prison and justice settings, we know we've got good figures for women in prison, and in Scotland we know that about 85% of women in prison have experienced significant trauma, and victims and witnesses have by definition have experienced trauma. So we now sort of thinking about why this might impact. We can look at the sort of trunk of the tree and just pick out a couple of difficulties. We know that trauma can lead to difficulties managing emotional reactions in the present. And the way we think about that is that people have often developed sort of an oversensitive and overdeveloped threat system, which makes sense when you think about what people are trying to live with. We often liken that to having a sort of set, because of your early experiences, to be triggered by things that maybe wouldn't normally trigger the smoke alarm. So imagine a child who's living with domestic abuse, who gets really good at being tuned into what might be about to happen, what's about to kick off, watching adults for clues for their safety. It's an extremely powerful survival mechanism in that situation, but that system has got to go into school, listen to teachers, play, chat with friends, all the time when your system is set up for threat. So it's a fantastic survival mechanism that really interferes with processes of learning. At other times, children and adults don't go into that flight or fight alarm system, but more into a freeze, flop, zoned out system as they try and reduce the impact of the trauma in their lives. And that leads to a whole other set of difficulties taking in and processing information, difficulties making plans, feeling switched off. And the reality for many people is they move between the two things. And that takes us into that second box in the on the trunk of the tree. Because if you imagine being wired for threat or being off, both of those situations are pretty exhausting and unsustainable. And therefore it's not supposed to try and make them feel more, sort of more brought back into what we call the window of tolerance. And people will use whatever works. And what works are alcohol, drugs, self-harm, overwork, overeating, and all of these work to tune this down or tune it up if you're so all of these are ways in which the things that we're often trying to help people with are the solutions that they have been trying to make to the trauma reactions that they have. Third box there is about trust. And this makes sense. Trauma happens often in relationships with other people, and recovery has to happen in relationships with other people, but your experience is people are dangerous. They're not safe, they don't do good things, and therefore it can be really hard to trust the people that you need to access for the life chances that you want and the services that you want to provide across health, across benefits, across education, across employment. And these create these additional barriers to people accessing the kind of services that you so well provide and that people could so well benefit from. So as we look at the consequences of all of this, we can see, we've already talked about higher levels of drug and alcohol use, that's obvious. We also know that that's at least a contributory factor for some of the drugs deaths in Scotland, across a whole range of other things. We can understand the understanding drugs and alcohols from this particular perspective can help us to make connections that are compassionate and reduce stigma. So the evidence is also irrefutable about the link with mental health, but that can also overshadow some of the impacts across other health impacts. There are really strong evidence around the links across all non-communicable diseases, so hearts, cardiac difficulties, strokes, cancer. These are strongly dose related in that the more trauma you're exposed to, the higher risk. And we have data that's from studies such as the ACEs studies, the Adverse Childhood Experience studies, that show that those particular types of trauma, if there's 6 or more of those in somebody's life, that can accumulate to a potential 20-year impact on life expectancy. But we also see the impact across a whole range of other things, not just in terms of the health impact. We've already talked about the impact on potentially accessing other services, around the risk of being numb or switched off or overreactive in an education or an employment context. And these are the elements that really emphasise that trauma is everyone's business. But adversity and trauma, all of these outcomes are absolutely not an inevitability. Adversity is not destiny, and there's lots that we can all do. So just when I was a therapist, no matter how awful the things I was hearing about, my next question was always, who was there for you? And what people sometimes told me about, if they were lucky, is that they talked about a granny who gave them mince and tatties on a Tuesday and made the world feel safer and more predictable. Sometimes they talked about a neighbour down the street who just always smiled warmly and made them feel noticed and gave them another model of how people could be. I would often hear about, for an example of a young woman who talked about a youth worker who took an interest and got involved in some activities and said to her at some point, "What's happening is not your fault." And she described hanging on to these words for 20 years, and they've been absolutely key to her recovery. So these are not therapists, these are just your average person doing all the ranges of services we provide that offered a relational experience that we would now frame as being trauma-informed and responsive. So this is about moving from shame and blame to contain and explain. It's not about reducing expectations, but about giving an understanding and a perspective and offering a different compassionate and connected relationship which gives people the best chance of success. So what we've gone in the National Trauma Training Programme is design a whole range of training resources and working closely with improvement services and work that Laura does and other partners, thinking about how we implement that across the piece. But taking our training resources, we've got our 4 practice types and thinking about what the differing needs of the workforce in different roles. So some of this is just really basic information, such as a trauma-informed dentist or a midwife being able to safely and effectively do an examination that might be considered intimate or invasive, or a care worker being able to complete personal care using these core principles. Where there's likely to be higher prevalence of difficulties and more complex problems, we have sort of enhanced and specialist training. So a good example of that is a sort of recently award-winning trauma-informed cervical screening project, which involved nurses trained in trauma working with survivors of sexual violence to increase the uptake of cervical examinations, because those very folk were both at higher risk of poorer outcomes in terms of cancer, but also more likely to avoid the examination. We know about substance use workers that are able to support people making links between these experiences and the substance to sort of increase that compassion, reduce stigma. And there's some fantastic work happening in education around the nurture approach and the sort of idea of connect before you correct. So lots of examples of where this has been done incredibly well in services. So there's some evidence emerging that also the workforces that are trained in trauma-informed and responsive approaches also experience better well-being themselves. And given that, as we all wrestle with the challenge of the stretch on the workforce at the moment, and recognising that our workforce is our most precious resource, this understanding, this key element of a trauma-informed and responsive approach is around recognising the way in which the workforce is able to be supported as part of this using the key principles. And we see this in a number of the Pathfinder projects in terms of the need to start with our workforce. So really want to emphasise that although training is important, it's only part of the picture for sustainable long-term change, and that implementation science approach that we are taking for all of this, and as I say, close partnership with improvement services and a whole range of different partners. So we want to move away from what's historically had been seen as slightly tongue-in-cheek as the spray and pray approach to training, to a more systemic and whole system approach. And as part of that, we looked at the research at the start of this process that understood what makes this stick and what's going to work in the longer term. And utterly key to this and utterly predictive of good outcomes was the engagement with leadership and the roles that you all have. We've looked at the evidence, we've done work internally in Scotland, and we know that leaders need to embody this and invest in this. And we've invested a lot in the Scottish Trauma Informed Leaders training, and we're starting to see the impact of this as we follow up people who've completed this training earlier. We did some early research with some key leaders across the field, and the research told us that leaders, summarised down, says needed to be this, be it, do it, and stick with it over the years. So I'm very conscious of time, so I'm going to wind up, but just wanted to sort of flash up this, our pledge. This is a snapshot. This is only a few of the 50 organisations who've signed up to our organisational pledge, and it shows the breadth of engagement across Scotland and different organisations. I'm really proud of all these partnerships and really value all these relationships across agencies. So this is about how we all kind of bring together those principles of trust, collaboration, choice, empowerment and safety, so we can pull all this together. And as I've said, Scotland's already a world leader in this, and but it does feel very embryonic. A lot of work around joining the dots, and the kind of leadership that you bring to this will be absolutely key going forward. But an exciting time. So I'm hopefully met my ambition about the timing, and I can pass back to Peter. Thank you.
Thank you so much, Peter, and hi everyone. Thank you so much for having me along today. I really don't have a lot of time, so if I am going too quick, please just don't hesitate to let me know. But today I'm here to talk to you about what we can do to support people who are affected by trauma. And firstly, I would like to start off by telling you a little bit about the organisation that I work at. So Resilience Learning Partnership are an education and training provider with a dual purpose. We work across health, social care, education, housing and criminal justice. We inform policy and strategy through our work, so we don't just do education and training services, but we're very privileged to be able to support organisations through changing their policy and implementing those policy changes as well. We're a lived experience led organisation, that's what they call us, and around 95% of my workforce have lived experience of psychological trauma, as well as a whole load of other professional experience and qualifications. Our vision as an organisation is quite simple. It's that people with lived experience are valued and that they're thriving, that they're supported by authentic and meaningful relationships within safe and nurturing environments, and they're at the heart of public policy, decision making and service design. And the mission, so how we will see that vision through is for us, it's about creating space for people with lived experience to be heard, valued and supported, enabling them to discover their own potential and realise their own ambitions. Trauma can take an awful lot away from people, and we're all about restoring that. And it may look different depending on every individual person that comes through our door. It's not about our agenda, it's about what people want to regain back themselves. And as a lived experience led organisation, as I said, we influence positive changes across not just organisations, but hopefully now across Scotland, enabling services to better engage and support people with lived experience. That's what our work is all about. As Sandra highlighted, there can be a real lack of engagement and the services that we need, health services, education services, the simple services that might be in our children's lives as well. It's very difficult often for people with lived experience of complex trauma, and some things need to change and adapt so that we can start to seem like a much more less frightening place for some of those individuals, and that sits very much in trauma-informed practice. For us, our priority and commitment areas are about realising aspirations, building social capital for people and influencing that all-important change. And you can learn more about us and that strategic side from our strategic plan. You can find that very easy online. And also we are co-authors of the National Trauma Training Plan and work very closely with Scottish Government as well as NES and IS and other partners and stakeholders and the continued implementation of trauma-informed practice across Scotland. So I'm not here today to talk about the organisation that I work at. I've given you that kind of high level idea of what we do. Instead of telling you about what we do, I want to show you what we do. So I'm going to take you into a bit of a live piece of work that I've actually specifically redesigned for today. Normally we would all be in a room together, we'd have paper out on the table and cups of tea and cakes, and we'd get right into this, but we can't do that today. So I'm going to talk through this activity, and I hope it still lands as well as it's supposed to. So we're going to look at one case study activity and consider each of the factors as we move through it. I will then present and consider some questions, and then I will present some conclusions to the exercise. Please feel free, though, to jot things down, make notes, or contribute in the chat if you want. So this is case study A. This is Shannon, and I want you to think of Shannon as about 19 years old, the last age we see there on the bullet point list, and I'm literally just going to read through that list. So Shannon, both of Shannon's primary caregivers are alcoholics. She's lived in various women's aid refuges as a child. She's witnessed extreme amounts of violence as a young person and as a child, and was taken into care at age 13 due to mainly being at risk of CSE, which is childhood sexual exploitation. She leaves school at age 14 with no qualifications and has multiple convictions by age 19. She experiences homelessness as a child, as a teenager, and as an adult, and as a teenage pregnancy, age 19. And also her first serious relationship is domestically violent. So normally I would give you guys those questions to go away and consider yourself, but I'm just going to kind of read through them and talk through some of the general responses we get when we do this in a workshop environment like this. So first question we always ask is, what might the impact of trauma be on Shannon? And Sandra touched on so much of that there. So we often get responses back like poor physical health, poor mental health, high-risk coping strategies, difficulty trusting professionals and forming relationships. Sandra really touched on that in her presentation. We also asked what might be missing from Shannon's life due to the trauma that she's experienced. So healthy relationships might be a common answer we get back. Connection, trust in services and professionals again. Nurture might be very much missing from Shannon's life, people will often say. People who understand the impact of trauma may be missing from Shannon's life. Often those people might sit in the services that Shannon might be accessing. Number 3 question is, well, for today, actually, I adapted it slightly. What might a trauma-informed response look like for Shannon? So when we ask this kind of question in a general sense in workshops, we get back like recognition and of the trauma and the impact that it's had on Shannon, us generally recognising that in children, young people and adults, understanding trauma in schooling, within education, within our curriculum design. Trauma-informed support for parents is something that's more commonly coming through, us beginning to understand the impact of trauma on parenting, for example, and the tensions that might create with child protection. Ending sibling separation, we're safe to do so. Scotland's made some really great step forwards in doing that through the promise. Less young people in care, another step forward that we're very much taking in Scotland. And as I said previously, a real understanding within services and child protection, the impact of trauma on parenting. And when we do the case study activity, the last question that we always ask is, what does the future look like for Shannon? And we get so many different answers back. And over the past 4 years that I've been doing this, it very much has evolved, and it tells us a lot about where people are at on their journey and becoming trauma-informed. The biggest part for me of becoming trauma-informed is about understanding the impact of trauma. Just by doing that, it helps us understand so much more of the world and what's going on in it. But we do get a lot of negative stuff back often about Shannon, which is she might be in prison, she might be dead, our own child might be in care, the cycle of abuse and addiction continues. And where that was done in the early days, it was most commonly only negative responses we would get back. now those responses are becoming more and more positive, or really full with lots of sentences about what people might be able to do, the different approaches people might be able to take, the understanding that's required perhaps when working with someone like Shannon. So those answers are very much evolving. And we still now are getting a few wee positive ones in, which is absolutely brilliant, which always makes it so much better when I do this part of the case study and let everyone taking part know that actually Shannon is my case study. So the future is me for Shannon. I am Shannon's future. And this is how we do what we do at RLP. We take people's lived experience and we blend it with a professional and academic experience and use it in spaces like this. So it's only myself and two other people at RLP who currently openly share our lived experience in this way, and then everyone else who works with us feeds into the wider work that we do. But helps people understand that, you know, somebody like Shannon isn't just a case study plucked out of the air, although I'm sure when you've worked with case studies before, they often are plucked out of the air or they're highly anonymised and we don't ever see the person behind them, and that's absolutely fine and right a lot of the time. But actually it's really good to remember that there are many Shannons out there, and that Shannon is very much actually a real person. This is a real person's story and it's my story. So I hope you were all pleasantly surprised by that and not too shocked, but I want to go back to the rest of the questions and answer them in a bit of a different order. So what might the impact of trauma be on Shannon? The list that I gave before and that people often respond back with pretty much was all of the above I had as a young person and as a young adult. Poor physical health, particularly around things like dentistry and not engaging in things like smear appointments because life was really chaotic. And forming relationships with professionals was very difficult for me as someone who left school very, very young because I was so disruptive and such a troublemaker for the school. It was much easier just to get me out of that environment. So, and when I went into care as well, they tried to force me back into a secure school, and that just further compounded how unwilling and unready I was to be able to sit in a classroom and learn and concentrate and get on with my peers and the professionals who taught us. What might be missing from Shannon's life due to the trauma that she's experienced. So for me, I was very misunderstood as a young people. I don't think people around me very much understood the impact of trauma, and I was labelled that bad, disruptive kid that, you know, won't listen, won't do what they're told. But I'd experienced a hell of a lot of trauma. This bullet point list that you have is just a wee snippet. It's what's safe for me to share with you all today, but I'm sure you can all put two and two together and read between the lines of what that really would have meant for me and how much trauma myself and actually my brother would have been experiencing on a daily basis. So being really misunderstood and labelled, we still do that with kids, and it's a lack of understanding of trauma that makes us do that. I was very isolated as a young person. I got more and more further and further away from my support systems, from my family, even though it was chaotic and traumatic. It was my chaos and my trauma, and being ripped away from that and put in an isolated place in care was really not the answer. More support from my mother to leave her abusive partner and to get a grip on her addiction would have been so much better. Getting out of the women's aid system and into secure housing earlier would have been much better. My mum being able to get out and get a job and do something with her life would have been much better than just ripping me out of the family home, because that's where I went right back to in the end up anyway, and where so many of our kids do go back. Opportunities to stay engaged in education were very lacking at my time of life. I know that has significantly changed. I'm a teacher myself now, and I know that it is different. Schools are notified straight away when a young person goes into care, and some supports are put in place, but we're also very quick to remove young people from their school environment without fully understanding what we need to do to actually keep them in there, or looking at alternatives like a break from education. You can't really do that in the UK without being at a real disadvantage, and it'd be nice to see more of that kind of approach being introduced I had no social capital, which is funny that I ended up going and starting an organisation where one of our core priority and commitments is creating social capital, because that was something I was really lacking as a young person. And I was really lacking in an ability to engage within services as well. And what might a trauma-informed response have looked like to Shannon? Well, only now is my trauma recognised as an adult through being able to engage in trauma-informed services and therapy, and we need to recognise it much earlier in our young people to save them a long time and continuously been going around the system. I'm sure you all know the stats around young care experienced people, for example, and the prison population. 67% of Polmont young people have previously been in care, and that's a kind of a damning reflection on what happens to our young people when they exit the care system. Being able to access the services that we should. So health is a big one for people. Dentistry, cervical screening have been talked about today, but just the ability to go to your GP and frankly talk about what may have happened in your past or what may be going on excuse me, for you just now. It's very, very difficult. Sometimes it can be just so much easier to just go, I won't deal with that. I don't want to go and see that really rude person in the GP's office who thinks I'm just another number. It's just really easy to ignore and forget. And I don't know if anyone here has seen the Opening Doors video or if that's planned for future, but that highlights really beautiful the difference that just those initial interactions through understanding trauma better and having an awareness of what trauma-informed practice does for our staff who actually don't work directly with people with lived experience of trauma. And lastly, I just want to finish on, because I know my time is up, the most transformational thing for me, and the thing I often say, and I know some psychologists won't like it, is education healed me way more than trauma therapy ever has, and I think ever will. Education gave me back so many of the things that I didn't even get a chance to get. I will never be poor again. I will never be homeless again. I will always be able to get a job. I feel empowered. I feel knowledgeable. I don't feel worthless. I don't feel stupid anymore. And education did that for me. It was like getting a chance to go back to school as an adult, going to uni at age 29 and staying on for 6 years and getting myself 2 degrees and realising a lot of the things that I thought and was told when I was a young person simply weren't true. I was just very healthily reacting to the trauma that I'd been experiencing. And education can be transformational for people with lived experience of trauma. So I will leave it there. I would love to answer any questions later on in the session or talk to anybody after the session as well. So please take a screenshot of our contact details and feel free to get in touch at any time. Thanks so much for listening, and I'm sorry if it was a bit of a sprint.
Thanks, Peter. Really good to see everyone today. As well as my role as Aberdeen City IJB Chair, I've also worked for over 25 years in the third sector around services for problem drug and alcohol users and also for women experiencing gender-based violence. So that's taught me a lot about trauma-informed practice and really has made me really firm in my belief that trauma-informed practice leads to effective engagement with all people. So as an IJB chair, I've taken this into how I work at the IJB, and my approach is really that trauma-informed practice shouldn't really be seen at all as a siloed way of working, another box that we all have to tick as IJB chairs, but really it's a way of working that can underpin all our practices, our policies and our systems, and it actually supports the existing strategic IJB priorities that we already have. Next slide, please. So we've already had petals and we've had a tree, so I'm using an onion. So if we think of our IJB and our local health and social care partnership as an onion with lots of layers in it, and at the centre of the onion are the people that we're caring for and we're providing services for, and there's lots of layers around that, including how we consult with our local population, who's around our strategic planning groups, and then the outer layer being the IJB itself. And I really believe that we need to have, that whole onion has to be trauma informed, and we have to live the the petals that Sandra spoke about through all our interactions. So today I want to just give you a few examples of how we've done that in Aberdeen IJB through our approach to our culture and leadership as an IJB, how we have used trauma-informed approach to tackle inequalities through how we engage with our local communities, and also provide some examples of how this is leading to better quality of services being experienced by people, you know, right at the centre that we're all here to serve. But I would also just put out there a disclaimer at the start. I'm not saying at all that we've got this absolutely nailed as an IJB. We've got lots more work to keep doing to widen awareness of trauma-informed practice and make sure that our trauma-informed approach isn't just seen as something that frontline services need to do, but that leadership at all layers within our onion need to understand trauma-informed practice and understand why it really is important. So next slide, please. So I hope that what I share maybe just generates some ideas for your own IJB to think about, and it may be that you're already doing a fair bit of this. So the first area that I wanted to tell you about was our approach to culture and leadership. So for me, there's a real central importance of building relationships in our culture and our leadership approach at the IJB. You may well know, and I think probably heard from what you've heard from Shumela and Sandra, that evidence shows that safe and supportive relationships are the best predictors of recovery from traumatic experiences. But we also know that the importance of strong relationships and creating psychological safety is a key factor in effective leadership in complex systems. So you'll probably be familiar with the work of Michael West and others. So for me, trauma-informed practice absolutely aligns with a compassionate, collaborative leadership approach. And I'm pleased that that is very much present in the North East system of health and care. So for me, that's kind of a foundation that we can set in our IJB. And if you think again of the onion, that our approach, how we interact with each other, how we ask questions, how we engage with the rest of the system influences the wider culture throughout the organisation. And some deliberate things we've done, I've just put them on this slide here. We've deliberately put a real value on informal spaces, created space where anyone in our IJB can ask any half-baked daft laddie, daft lassie question without feeling that they're going to be judged in any way. We have deliberately reduced jargon, acronyms at the IJB in our papers, and we have removed use of titles in our IJB interactions, so everyone is known and referred to as in their first name. We're really aiming there for all voices to be heard equally. We make absolutely no difference whether it's a voting member or a non-voting member. We've also had some development sessions with our IJB and our leadership team where we have worked on getting to know each other more behind our labels, more about the people that we are. And one really interesting example we've had is we've all presented boom boards. I don't know if folk are aware of boom boards, but the boom stands for best out of me. And each person on the IJB and the leadership team has been asked to present just a one-page, like a PowerPoint with pictures, which tell a story that defines them, what's their likes, dislikes, and generally share some personal elements that people are comfortable with to help us connect as people around the IJB table, and to make sure that we get the best out of each other through working together. And that's been really effective. We'll carry on doing that. We also do a grounding exercise at the start of each IJB. Usually we start with a short film, maybe 5 minutes or so, which just reminds people why we are all together as an IJB, what our focus is, and helps people leave all the other meetings that they've been to, hopefully outside, and focus on our IJB priorities. One of those examples that we've done is we've actually showed the Opening Doors short film as an exercise at the start of one of our IJBs recently. So you might think, well, why does this matter and what difference has this all made? Well, my strong belief is that through taking a deliberate approach to our culture and our leadership style, that has created psychological safety within our IJB and our leadership team that's enabled high quality conversations to take place, so that we've been able to challenge and scrutinise effectively, and we have taken really brave decisions around our strategic service redesign. So it's been really important and something we'll continue to work on. Next slide, please. So I could spend all day talking about this graphic, but I won't. I'm sure that IJB colleagues will be familiar with what's laid out here. And with many other IJBs in Aberdeen, we recognise that some people will need additional support in order to achieve the same health outcomes. So we need to design our services which consider the diversity of our people and how we can remove barriers to engage in an effective outcomes from services. Obviously, ultimately, our longer term aim is to remove the systemic barriers through our role as anchor institutes, but that's really for a different day. But just wanted to put that up there. So a trauma-informed approach tells us, as we've heard already, that people who have experienced complex trauma may feel unsafe in settings out with their home. They can have difficulty forming trusting relationships and therefore can have less effective engagement with health and care services when they are not trauma-informed. So if we're really serious about narrowing gaps and inequalities, when considering redesign, our consultation and engagement approach really needs to ensure we hear seldom heard voices and put a real deliberate focus on hearing people who are furthest from our health and care system at the moment. So next slide. So how we've done this in Aberdeen is we've taken a deliberate approach where we recognise that we need to amplify seldom heard voices, because we believe that we've got most to learn from people that are furthest from health and care and people who tend to experience poorer outcomes. And these three here are just examples of how we're doing that through our planning processes. So the first one there is we have an equalities and human rights subgroup. This underpins all our strategic decision-making processes and includes representatives on it from our Grampian Racial Equality Council, the Scottish Refugee Council, and also people with lived experience. We're currently reaching out to our faith community to look for representation, because we recognise that our local faith community are more likely to have contact with people who have experienced complex trauma, and we want to pull their views and experiences into that group. We all do health inequality impact assessments for all our service redesigns. We have put specific importance in our health inequality impact assessment on specific groups. So not only protected characteristics, but people who are at risk of being homeless, people with substance use issues, and people on low incomes. And through doing that, we believe that that will help us hear and understand more about people who have experienced complex trauma. And the third example here is that we have 3 place-based locality empowerment groups, which we call our legs in Aberdeen. So we've got 3 legs, which is maybe not as many we're supposed to have, but they're based in our south, central and north localities in the city. And that's where we're proactively engaging with local members of the community on an ongoing basis around our plans. And that's really about the importance of building on forming relationships, building trust, and avoiding sort of drive-by consultations where people are asked something and then they never really hear what happens. But it's that building trust. And interestingly, we're hearing that, so our legs have been in operation for 3 years now. And over time, we're seeing that trust is really being built. People that are coming to our legs are sharing really personal and deep issues with the partnership staff. And that has led to wider changes in services that we would never have been able to pick up through just a questionnaire or you know, a kind of the standard way of maybe doing maybe doing sort of questionnaire type consultations, but having these legs that are there and where there's regular contact with the same people has really helped deepen our discussions and conversations with people in our communities. And there's, you know, direct examples of how we've been able to draw in experience from some older people to help with GP communications. We've developed a more nuanced approach in service about how we engage better with people who are sensory impaired, just for example, but lots of good stuff coming out of that. So I think what I'm trying to demonstrate here is our overall approach at the IJB ensures that our decision making at the IJB is underpinned by a process which is informed by the views of people who are more likely to have experienced complex trauma, and we're able to evidence this at the IJB so that we can be confident in our decision making that we've considered people with complex trauma in our processes. Next slide, please. So I suppose the key question is this really making a difference to how people experience services? Well, the first thing I'd say, and you'll see here, safety, choice, collaboration, trust and empowerment. These are the petals on the flower that Sandra showed earlier. The first thing I would say is that these are principles that everyone, whether or not they've experienced complex trauma or not, these are principles that are about having a high quality service. Everyone needs to feel safe when engaging with a service. Everyone wants to have choice and feel that they're a collaborator, they're empowered to make decisions and that they can trust their service. So by being trauma informed, we're actually developing services that are high quality, which will benefit everyone. Next slide, please. So just a few examples of how this is working in Aberdeen. Hopefully you can read that, but I just wanted to put a few examples up. The first one is we recently had an inspection from the Care Inspectorate for our Justice Social Work services, and that was a really positive inspection, and the service was specifically praised for its trauma-informed approach. And what was interesting from that is that this is, from the service point of view, this is really about really practical things that services can do, the provision of flexible opening times, WhatsApp support group, women-only services, seeing people in their own communities where they feel safe. It's these type of things that really make the difference for people often that have experienced complex trauma. So really good to hear that coming through from Care Inspectorate work. Also, and I'm sure other IGBs will have done similar, our approach to vaccination delivery is where we have worked with our third sector and trusted groups to bring vaccinations out to people and to deliver that in places where they feel safe, and that's had a really positive impact. We're in the process of developing a new dynamic database for domestic abuse victims, which has been created with people with lived experience. And this is providing an online platform to support people who are experiencing and living through domestic violence, where they can access anonymously support, advice. They can hear about experience from other people, and if they choose to, they can access direct help through the website. So just an example of something that's really been led by people themselves and helped us improve our service delivery there. For this presentation today, I reached out to our GP community to see how they were getting on around trauma-informed practice, and I thought I would share with you that what the feedback highlighted was, again, it's often really small things that can make a big difference to engagement. So our GP colleagues were advising that the importance when staff have been trauma trained is that and that's really important, that it's not just GPs, but actually often there's reception staff that are getting trained on trauma-informed practice, has really helped staff reframe their thinking. So when someone comes in and they can be difficult to engage with or upset or angry, rather than thinking what's wrong with you, to reframe that to think what has happened to you in the past. And that's been a really important way that general practice have taken on board a trauma-informed approach, and I think has really helped many staff deal in a more productive way and a more supportive way for people when they present in difficulty. The other things that GPs, the GP colleagues provided to me was what's as important is the how that we engage with people as well as what we do. So their advice being that clinicians and practice staff can start with simple things like a welcoming hello, good to see you today, good to hear from you, how can we help you today? To finish each contact by thanking people for attending, thanking them for phoning, to think about the waiting room environment. Are there quiet areas? Does the environment make people feel comfortable? Think about the wording on signage and practices, the way language is used in letters, the wording that's used in web pages. All these things are really important for helping engagement in general practice to engage better with people who are trauma informed. Conscious of time, so I'm just going to jump along a little bit, and there's loads of other examples, but next slide, please. So back to the onion, and I suppose what I'm hoping that I've got across is that a trauma-informed approach is not just about service delivery. It's a way of doing things at all levels, putting value on creating safe spaces, creating choice, empowering people, collaborating with our whole system. It's a leadership approach which drives effective change as well as a litmus test for high quality services. So I think as IJB leaders, we can do a lot to lead in this area and support this really important agenda for our health and social care teams. Next slide, please. So I think just to finish with, I thought what I might find useful if I was on the other end of this presentation is to think about, have you paid deliberate attention to your own culture to ensure all voices are heard equally around your IJB table? How are you building in trauma-sensitive approaches into your consultation and redesign processes? Is your local workforce getting training on trauma-informed approaches, including your leaders, again, at all levels through your onion? And do you know who your local trauma champions and trainers are? Because there will be resources locally to help you with this. So I'll finish there, really just hoping that I've sparked some ideas, and I know I've rattled through that, so happy to be contacted after today if anybody wants to find out more of what we're doing in Aberdeen. Thanks.